How's everybody doing? Great, great, great. Thank y'all for coming out tonight. And hopefully we have a little information to impart to you. But I'm just going to sort of set the stage before we bring the expert up here, okay? So we're going to be talking about a cancer update, proven prevention strategies. That's kind of what I'm going to focus on. Hello there, I haven't seen you in a while. Yeah. I'm going to kind of focus on that a bit, and then Lucas is really going to talk about a lot of exciting stuff in some areas of his expertise. First of all, what's the most common cause of death? Well, it's sort of a trick question. How old are you? If you're less than 1 year old, it's congenital anomalies. If you're 1 to 44, it's actually accidents. And if you're 45 to 64, it is cancer. And if you're over 65, it's heart disease. But not even that's really the truth, okay? Because if you're over 65, and you, like some of us, and maybe you're taking care of yourself and you didn't inherit any bad things from your parents or whatever, it's actually cancer. It's actually cancer. Okay, 18% of all the deaths are due to cancer. Overall, it's the second leading cause of death, but it's the leading cause of death among women 40 to 79 and men 60 to 79. So it's a common cause of death. Now, we're keeping a lot of people alive with all these heart medicines and everything else that we're doing. So it should be a topic that is of interest to all of us. All right. So what's the most common cause of cancer deaths in men? Women. Lung cancer. Lung cancer is the top cancer killer of men and women. Okay, so here's some facts and figures. If you look, yes, prostate cancer is the most common cancer in men. If you look at the cases, it's the most common cancer. This is cases. But if you look at deaths, what's the top cancer killer in men? Lung cancer. Prostate is half that number underneath it. All right, what about women? Breast, yes, breast is the most common cancer in women, almost 300,000, but if you look at deaths, it's lung cancer. It's lung cancer. So we cure most women with breast cancer. What do most women with breast cancer die of? Old age. Okay, all right. So we've made substantial progress has been made in combating cancer because of prevention, early detection, and treatment. And we've got the expert here tonight to talk about some of this. But if we look at some of the trends in cancer, you can see how just cancer is more common in men, but in men and women, cancer deaths are coming down, which this is fantastic. And just some statistics here. There'll be about 2 million people this year that will be diagnosed with cancer. There's going to be over 600,000 deaths. 80% of all cancers in the United States are diagnosed in people 55 years of age and older. All right? Why? Because as we age, so does our immune system. And we've been exposing ourselves to a lot of toxins over time. So there's some things that we can do to maybe lower that risk. All right? So in the United States, about 41 out of every 100 men and 39 out of every 100 women will develop cancer in their lifetime. So it's common. All right. Now, the American Cancer Society came out with this statement, it's been about 6 years ago now. And they talked about the large number of cancers that are preventable and the number of deaths that are preventable. And about 3 years after that, they said, we need to focus on this more. And they actually came out with their guidelines for diet and physical activity for cancer prevention, which also, these same guidelines, reduce your risk of recurrence if you do have cancer. So it's even for those people who've been diagnosed with cancer. And just this month, they came out with a national cancer plan. Everyone has a role. All of the things that you and I can do to lower our risk of getting cancer, or if we do get it, to improve the outcome. And everyone has a role. You and I have to take on our responsibility. So thank y'all for being here tonight and taking on the responsibility of learning more about cancer. So in the guidelines that came out, in 2017, the American Cancer Society actually came up with 8 things that we can do to prevent cancer. They talked about cigarette smoking, excess body fat, excessive alcohol, physical inactivity, consumption of red and processed meat, low intake of healthy foods, ultraviolet radiation, and certain infections. So let me just spend like a couple of minutes just talking about each one of these, or less, because I want to get Lucas up here, okay? One is, as we know, cigarette smoking, secondhand smoke. Even though the number of people who smoke, it's plummeted from 42% down to about 12 to 13% of the population. That's still too high. So, as this slide shows, it's going down. Why? Because we made smoking socially unacceptable. And by doing that, we lowered the risk of lung cancer and a lot of other diseases caused by smoking. All right. The bottom line: don't smoke, avoid smokers, breathe clean air. All right. All right. Now, excess body fat. So how does excess body fat cause cancer? Isn't it just sitting there? No, it's not sitting there. That excess body fat is making this chemical called adipocytokines, which is a fancy term for inflammatory molecules. And the root cause of almost all disease is inflammation. That's what causes a heart attack, strokes, Alzheimer's, and even a lot of cancers. And so that's why we know that people who are overweight, according to the American Cancer Society, who have excess body fat, are at increased risk of at least 13 different cancers. Ladies, the big ones for you and I are cancer of the breast and cancer of the uterus. All right, but also some of the GI malignancies. All right, and the problem is, as we know, the incidence of obesity has increased, and obesity meaning a BMI of greater than 30. And it used to be, a few decades ago, maybe 13% of the population or so was obese, and now we're up to 42%. And this is wreaking havoc in a lot of areas of medicine, including the cancer docs. So their guidelines say achieve and maintain a healthy body weight throughout life, which means we've just got to do what everybody else is not doing, and eat healthy. Okay. Another is excessive alcohol consumption. And the American American Society of Clinical Oncology came out with a statement on alcohol consumption, saying that, the more a person drinks, the greater the likelihood that it's going to wreak havoc. And if you're a guy, you definitely shouldn't be drinking more than 2 drinks a day. And women, you definitely shouldn't be drinking more than 1 drink a day. But if you look at the bottom, they said, nevertheless, some cancer risks persist even at low levels of consumption. And a study came out of Canada just recently thinking if there was a safe amount, it might be 2 to 3 glasses a week. So it's best not to drink. So I always tell people, if you don't drink, don't start. And if you do, really look at how much you're drinking, and literally try to keep it to maybe less than 1 drink per day. Maybe according to a lot of guidelines, maybe 2 or 3 drinks a week. Physical inactivity is also one of those preventable risk factors. And the American Cancer Society goes along with also the American Heart Association, saying we need to engage in 150 to 300 minutes of physical activity a week. And you might be thinking, 300 minutes? Folks, there's a lot of minutes in the week. And that is a very small percentage. And we have to have activity guidelines now because we're not moving. When I was on the farm and ranch hoeing cotton all day, picking cotton all day, hauling hay, we didn't need physical activity guidelines. But now we're sitting in front of computers and TVs and cell phones. So we really need to be monitoring our exercise. All right. Another risk factor is poor diet. And what's the healthiest food consumption? It is plant-based. The majority of our foods should be real food, plants, not processed foods. And in their guidelines, they say a healthy eating pattern limits or does not include red and processed meats, sugar-sweetened beverages, and highly processed foods and refined grains. And if we're going to eat those, keeping them to a very minimum. I can tell you I have plummeted my meat consumption. even though I own a ranch. Okay, my cows are much happier. Okay, and I've gotten rid of most of them, by the way, and I'm finding other things to do with that land. All right, so because we rarely eat red meat anymore, and maybe Lucas can comment more on that in GI malignancy. So people always say, "What do you eat?" Well, here's some pictures of my actual plates. Here's dinner. It's a big salad, and here's sweet potatoes and beans and Brussels sprouts, and here's another one. And by the way, those noodles are not wheat noodles. Those are edamame noodles, which are higher in protein and lower in carbs, and broccolini. And here's I'm actually eating out at La Rive, and they have this beautiful vegetable platter, which is full of quinoa and roasted vegetables. And here's another one of my salads at home. And you might think, Patsy, that looks like dessert. That's actually a beet salad at a restaurant with different types of beets, real food. And just another one. In fact, I took a picture of one of my friend's plates at a restaurant, and she's actually here in the audience. She ordered a vegetable plate at a restaurant, and once again, some salmon and vegetables, but this is what we live off. Here's lunch: hummus, carrots, and kimchi. And once again, some chicken and vegetables, but once again, a lot of vegetables and maybe a little meat. That's what we ought to be eating, all right? And once again, just a lot of vegetables, lots of vegetables, all right? So I'm going through this pretty quickly. I just want to hit on the high points here because I want to get Dr. Wong up here. Ultraviolet radiation, lots of skin cancers, millions of skin cancers. I have had skin cancer. Why? I was born and raised on a farm and a ranch pre-sunscreen. Okay, now I've been able to get those under control and have not had one in 15 years because I'm going to wear sunscreen. I'm going to start taking care of my skin, wear proper clothing and all. So that's something that we can all do. Now, what about infections? What do infections have to do with cancer? What? Well, we know now that H. pylori is actually the cause of a lot of stomach cancers. And maybe Dr. Wong can tell us more about that. It's one of his specialties, GI cancers. Hepatitis B can cause liver cancer. Hepatitis C. Now, we have a vaccine for hepatitis B, all right, now. And HIV is associated with some cancers. But the big one now is HPV. How many of y'all have heard of HPV, human papillomavirus? Yes, it's the cause of cancer of the cervix, vagina, penis, and yes, mouth and throat. And many of these cancers are caused by infections that could have been prevented with behavioral change, if we educate people, or with vaccination, such as, hepatitis B or the human papilloma, HPV virus, or treatment of the infections. And I just want to spend a minute talking about HPV because being a gynecologist, this is something I've been dealing with for decades. HPV cancers that cause at least 46,000 cancers a year, 25,000 in females, 20,000 in males. And you see the HPV-associated cancers there. Cancer of the cervix, vagina, vulva, penis, anus, and mouth and throat. The most common HPV-associated cancer in females is cancer of the cervix. But the most common HPV-associated cancer in men is cancer of the mouth and throat. Cancer of the mouth and throat. And so we now know that HPV causes almost all cancers of the cervix, almost all cancers of the anus. I'm not talking the rectum or the colon, I'm talking the anus. All right? Most of the vulvar vaginal cancers, penile cancers, 70% of the cancers of the mouth and throat now are caused by HPV. What used to cause most cancer of the mouth and throat? Smoking. We plummeted smoking. All right? And now most cancers of the mouth and throat are caused by HPV. And now we have a vaccination which protects against most of these types that cause these. And the HPV vaccine is approved for prevention of cancer of the cervix, vulva, vagina, anus, and yes, mouth and throat. Approved, and it's approved up to the age of 45. All right. So cancer prevention, the bottom line, and this is just some direct quotes from the American Cancer Society. These findings underscore the importance of adherence to comprehensive guidelines on weight control, alcohol, diet, and physical activity. Folks, we all need to look at what we're eating, what we're putting in our mouth, because we're being offered a lot of unhealthy, processed, sugar-laden stuff full of chemicals. And we need to look at what is our physical activity level. Now, how much are we drinking? Believe me, in my pursuit of wellness, which this month it'll be 15 years ago, when my husband drugged me to a wellness conference, kicking and screaming. 15 years ago, April 2008. It was a game changer for both of us. I started lowering my alcohol consumption, eating healthier, exercising more, working on meditation. And believe me, we're not done, and we hope you guys aren't done. We hope you'll continue to travel this journey with us. And as it says here, indeed, large prospective studies have demonstrated that adherence to a lifestyle consistent with the American Cancer Society Cancer Prevention Guidelines for maintaining a healthy body weight, limiting alcohol intake for those who do drink, consuming a healthy diet, and being physically active is associated with a reduced risk of developing and dying from cancer. All right, so, and what are some of the recommended screening tests for women? Us getting our pap smears, getting those mammograms for guys, prostate cancer screening for men and women, colonoscopy, and I know Dr. Wong can talk about the GI cancers, and if you're a past smoker, getting lung imaging. All right, so the American Cancer Society says probably 42% of all cancers and almost half of all cancer deaths were due to modifiable risk factors, things you and I could have done. And that's huge. Not a 10% reduction, not 20%. We're talking half of cancer deaths. All right. And the combination of excess body weight, alcohol intake, poor diet, and physical inactivity account for the highest proportion of all cancer cases in men and women, and second only to smoking in men. All right. So once again, let's keep aware of these. And if you go to the American Cancer Society, I was even talking to Judy. She would say, and I went. They're updating their website on a lot of stuff. So it's important for us to all, keep posted on this. So what about cancer prevention? You and I need to make certain things unacceptable in our lives, just unacceptable. It's unacceptable to be physically inactive. That's Patsy Shulock. It's unacceptable for me to do that. No, it's unacceptable for me to drink too much. It's unacceptable. And we all have to look at what is something we're doing in our life that's it's going to be unacceptable, right? Because what happens when we make something unacceptable, like cigarette smoking? All of a sudden we plummet all the problems that are caused by that bad habit. So, and by the way, just like we're giving you good information here at Living Well and Bell, and we do at Living Well Aware, my wellness program, I'm happy to say that all the area schools are going to be taking on the Living Well Aware My Choice is My Life curriculum for the middle school students. We're going to be in Temple, Belton, Killeen, Gatesville, Troy, and we just finished it, and I owe it to my husband and my youngest son for helping me make it happen, and our adolescent team. So hopefully you'll be hearing a lot about that, because Belton will be rolling it out next month, and so will Killeen. And Temple is going to try to get it in. We'll see if they do, if not next year. And by the way, if you're not signed up for our free newsletter, Living Well Aware, go to livingwellaware.com and sign up for the free monthly newsletter. Okay? So, without further ado, I'm going to bring somebody who really knows what they're talking about. Not a dumb gynecologist, okay? But Lucas Wong is a medical oncologist, and my hat's off to anyone who devotes their career to taking care of cancer patients. And he does have a specialty in GI cancers. He could talk to you about that also. And he also heads up research at Scott and White. And anyway, Lucas, get up here. All right. And this is for the, here we go.
Okay. All right. Well, thank you everyone for coming, and thank you, Patsy, for the kind introduction, and hope everyone can learn something from tonight. So, cancer. So obviously, Dr. Sulak presented all the activities, behavior, things you can do to prevent cancer, but unfortunately, folks do develop cancer. So that's when they come to my clinic, and that's when they see me. So what Patsy wanted me to talk about today was some of the changes in oncology. I just want to share with you how things have changed from when I started my career into where we are now. So when I first started training, cancer was sort of a terrible disease, and it still is. Options were very limited, but we didn't really know much about cancer. And that has changed over the last several years. So I think I go back to Richard Nixon. Some of you may know who he is. Some of you may not. My children don't. But Richard Nixon was the president, and he declared war on cancer. And that was sort of the major funding for research in cancer. So back then, we didn't know much. But that research has led us to now the discoveries of how we are managing cancer now. And you probably hear on the TV and the news, targeted therapy, immunotherapy. That all came from the research way back then. But it took years to come to that point. So I'm just going to give you a brief flavor of how we went there. There's no way I can cover all that in the time that I have. So just to give you an example, people, you walk around, you may hurt yourself, cut yourself, and you have an injury. So what does your body do? It regenerates itself. It has signaling, has ability to heal itself. So what happens when the healing process becomes abnormal or out of control? Well, that is what you would describe as cancer. And so one idea there, and they found this out, is that we have genetic alterations, gene mutations, and these are and there's two versions of it. They call them tumor suppressor genes and proto-oncogenes. Fancy word, but basically think of an accelerator and a brake. And you have genes that promote growth of cells, which makes sense, you're healing, and then you have to stop the healing, otherwise you grow out of control. What happens in cancer, these mechanisms become abnormal, and they were able to determine these mutations, genetic alterations in the cancer cells. So now you have cancers that can grow out of control, they don't stop, or you have the ability of not having a break, and the cancers you can't stop the car from moving, so everything keeps on growing. So that is what they led to discovery, and this then led to the idea of gene sequencing. And you probably heard of the Human Genome Project. Have you heard about that?
Yeah.
Okay, so what it is, you're mapping out the genome, the genetic makeup of the cancer. And they have, of course, normal genetic findings, but then you have abnormal, and they were able to sequence these mutations or genes in different cancers. Breast cancer, colon cancer, pancreatic cancer. And they have found certain gene mutations that are unique to each cancer. And that allows you then to discover, well, now that we know these mutations lead to cancer, can we target them? And that led to the idea of targeted therapy. Okay, so then you know this mutation, you develop a drug, find a drug, targets that mutation, shuts the cancer down, and then you can put the cancer into remission. Now, you can't always cure it, but at least can slow it down. Mortality for cancers back when my training was 3 to 6 months. I have patients now who are living many years without, free of cancer, or at least under control. I didn't say cure always, but we've changed cancer from a very illness that would kill you probably in 3 to 6 months to now where you can live years or even decades with cancer. So that is targeted therapy, and that's what we're talking about. So that's one group. Another group, and I'm just, by the way, these are broad strokes, so I can't tell you everything, immunotherapy. So people start looking at the immune system. And we probably all develop precancerous conditions, but our body has a way to prevent these cells that are becoming abnormal to become cancer. And we hypothesized, and they found that the immune system is a way to keep it under check. Our immune system is there to prevent you from getting sick from infection, viruses, bacteria, but it also has the ability to shut down precancerous conditions. Okay, and so people start speculating, well, can we alter the immune system so that it can now attack cancer? Okay, so the immune system is a very powerful tool, and they did a lot of research. I refer you to James Allison. He's the one who developed the idea of immunotherapy, and he's the one that figured out there are different cells, B cells and T cells. Probably these are just type of immune cells that we have in our body, but the key one for him was the T cell. And so what he found that the cancer cells have proteins on the surface of it, and these proteins will tell your immune cells not to attack it, to let it camouflage, like a shielding. So they will grow and grow and grow, and your immune system will not recognize it, and that's what happens. So then he said, well, why don't we develop an antibody which is a protein, to block the cancer cells from so that your immune system will now recognize it. So think of it as camouflage. Now you have a man-made antibody to strip out the camouflage. So now the immune system says, oh, this is cancer. We should attack it and get rid of it. And so he developed this, and this is the genesis of immune therapy. Very effective in melanoma, renal cell. But then they started looking at other cancers. And remember I talked about those genetic alterations, mutations? Some of those are very immunogenic. And so guess what? They found that some of them will help stimulate when you have that, the immune system can be activated against it, and they combine the therapies to attack it. So now we're using immune therapy in other cancers that we never thought we ever used. So the big one is lung cancer. We use it a lot more in lung cancer. We're using colon cancer, endometrial cancer. And this is when your oncologist will say, I have to run more tests. Well, when he's saying running more tests, he or she, they're looking at genetic alterations and also whether these cells, cancer cells, are sensitive to immune therapy. So those are the big concepts that we're seeing right now. So when you watch on TV, they've got immune therapy, targeted therapy. Well, there are drugs now specifically targeting every genetic alteration. And for me, lung cancer is a big one. Lung cancer now has like about 10 maybe different genetic alterations. And we have drugs for each one of them. So what we thought was just lung cancer, just lung cancer, they have now self-segregated out into all these different categories. Each category has one drug that will target each one. So that is really cool, very different, and just so much different than how I was in my training. Okay. So these are just sort of principles I want you to recognize what's happening for oncology. So what do? I do GI oncology. So I take care of patients with GI cancers. And Dr. Sulek sort of showed you some of the common cancers. But the most common cancers, GI cancers, are going to be colon and pancreas. And a lot of it is related to diet. People don't eat enough vegetables, don't do exercise, and we feel that is a major component for colon cancer. And the biggest thing you all should do is get your screening colonoscopy, which was 50, but now it's dropped to 45, and that's brand new. That just happened about a year ago. They're now recommending everyone get screened for colon cancer starting at 45. So why did they drop that down? So a little known fact is coming out now. We are seeing actually a rise in colon cancer. Now overall the incidence is coming down, but there is a certain group of folks that we're seeing an increased rise in colon cancer, and it's people below 50. It's called early onset age of colon cancer. Some of you may watch those Marvel movies. And I don't know if you remember that one with the Black Panther, the actor, the main actor. He's had a colon cancer. He's 45, advanced colon cancer. And I can tell you in my practice, I've seen a migration of patients with colon cancer from the older group to a younger group. Because the older group, most of them are getting a screening colonoscopy. Everyone knows that. Your primary care physician is going to tell you, you need to get a colonoscopy at 50, then at 60 and 70. Guess who wasn't being screened? The younger folks. So we are seeing an increased rise. Once again, hypothesis, lack of exercise, lack of good diet. We think that's what's going on. So I am seeing lots of patients much younger than I ever expected. I've seen in their 20s, 30s. I think the youngest one was 18, and that's just amazing. So it's very hard to tell someone that age you have colon cancer, and a lot of times it's advanced because when you're that young, you don't think you're going to get colon cancer, so it's a surprise. So I'm very aggressive at screening colon cancer, especially those with family history. And another thing, anyone who has colon cancer below 50, we recommend 10 years earlier than the state for screening. So if you were diagnosed at 50, you'd be screened at 40. If you're diagnosed at 45, you'd be screened at 35. And you can tell your insurance company, they will do that. Okay. So that's an important concept for you all to know. The other thing that's happening is that we're seeing an increased rise of pancreas cancer. And that's a very tough one to treat. We made, even with aggressive surgery, chemotherapy, radiation, only 10% of the people we ever diagnosed with pancreatic cancer is ever cured. So that's pretty tough. And so that is going up in incidence. We suspect probably in about 5 years that pancreas cancer will succeed colon cancers and then one GI cancers. So something to think about. So what else do I do? I'm also very active in clinical trials. And I don't know if Dr. Sulek knows about that, but we recently, with collaboration with my wife, Dr. Go, who's in the audience, we submitted a grant to CPRIT, Cancer Prevention Research of Texas, with UT Southwestern and JPS, and we were awarded a grant to expand clinical trials in Central and Texas. And it's about a $3 million grant. So we're in collaboration with these institutes to expand and increase clinical trial participation and enrollment in all of, from basically North Central Texas. When I do clinical trials, and what are clinical trials? We are looking at different treatments, right? So you find a mutation, you find a drug to attack that mutation, you have to test it. And how do you test it? You do a trial. Now, trials means you compare patients who take the drug versus not take the drug, and that's how we do it. It used to be really easy because you didn't break down the patient population. What's more challenging now is that every colon cancer patient is now segregated into these separate categories that we didn't have before. So now I have to screen 100 patients to get maybe 10 patients to figure out one patient who may be eligible for the study. And then we have to ask the patient, do you want to participate or not? So the complexity of studies has gotten much harder. And because the complexity has gone up, guess what? Studies have become more expensive, harder to conduct. That's one reason why the drugs are so expensive. We haven't touched about drug costs, but to give you a reference point, typical oral chemotherapy drugs for targeted therapy, about $15,000 to $20,000 a month, and that's without insurance. Thankfully, if you have insurance, it's not that bad, but if you don't, a little more challenging. So the cost of drugs are going up, and partly because the cost of studying has become more complex. So I think that's where we're at. But I'm very big proponent of clinical trials, supporting research, because I think that's the way we get the new drugs into the community and to hopefully cure cancer. So those are some of the things I've seen. I think at this point, yes.
You can tell them how successful the new medications are.
Okay.
Because remember, lung cancer was a death threat, but
Yeah.
now.
Okay. So what Dr. Go is bringing up is that there are some cancers that we have definitely cured, or at least made a big difference. So a classic one is probably, in my mind, the biggest one started with a medication called Gleevec. It's for chronic myelogenous leukemia, also drug active in gastrointestinal stromal tumor, a very uncommon cancer. They have found with that one there was a mutation, BCR-ABL, and it's just a proto-oncogene, makes the cancer grow. And what happens with that mutation, these proteins fuse and cause the cancer to replicate uncontrollably. And when they discovered this mutation, a company, Novartis, was able to generate a drug to block that mutation, shut the cancer down, and it was a key and lock. Once you get the key, it goes into that mutation, shuts it down. And they found it was a major game changer for chronic myelogenous leukemia. This chronic leukemia, I don't want to go too much there, but it was a cancer we really couldn't treat unless we did transplant. With this medication, you didn't need bone marrow transplant. You would just take a pill, and it was amazing. They found that same mutation in gastrointestinal stromal tumors, and the same thing. People were going into remissions, cancer under control, just amazing, just amazing. And so there are other targeted therapies we're having similar results in. Some not as successful, but some so. And in terms of successes, I think immune therapy is another one. We have patients who have certain genetic mutations. If you give them immune therapy, once again, you can get complete remission, cured, and patients are living free of cancer. So I think there are definitely miracles are happening. The hardest thing is that it doesn't happen to everybody, right? It's a smaller percentage. I mean, the percentage we have now is better than what we had before, which was 0, but we still have them. But I think we're making progress. And then, once again, research trying to figure out how do we expand that patient population? How do we do it? And that goes back to clinical research, the trials, trying to figure this out. And this is ongoing right now. And so, and as I conduct trials, and by the way, I'm not these studies are open at various medical centers across the country. So you may have to have 100 centers, each enrolling maybe 1 or 2 or 3 patients to get enough volume to really make a difference and see a difference. So, okay. Any questions, I guess? I sort of give you my, yes?
I have a question.
Mm-hmm.
There's a lot of screening for various cancers that can detect cancer, but there's not too many for the liver. So does a CT scan with contrast imaging detect cancer of the liver?
So let's just back up a bit. Liver cancer is something that's commonly associated with excess alcohol consumption, exposure to hepatitis B, hepatitis C. So the first thing you want to do is, are you at high risk for that? If you're at high risk for it, then there are some guidelines for screening. It depends on which screening guidelines you look at. I don't do too much for liver cancer screening, so I'll just give you a heads up there. But what I've seen people do in our liver clinic, they consider abdominal ultrasound to look at things, other things, MRI. I think the challenge is, obviously, these tests can be expensive, and what's the yield for that? So I think what a lot of us will look at is that what is your risk for cancer, and based on the risk factors, sort of risk stratification, then you are focused on the screening process. And there are guidelines out there. You can look it up. The U.S. Preventive Task Force will tell you what they may be, things like that. Sure, yes.
You talked about the increase of cancer of the pancreas.
Mhm.
Extremely rising quickly. What do you contribute that to?
I think, once again, we're not quite sure. We know tobacco is one risk factor, but tobacco use is going down. So then the next thing that most of us are concerned about is obesity, lack of exercises. But I'm not quite sure that explains everything. I've seen young people with pancreas cancer. I think they're probably maybe some of the environment. This is all speculation. I don't know why. But I think there is an increased rise in some of which we haven't totally figured out yet. So that's an active area of research, quite honestly. Yes?
From Dr. Shulak's slides, it sounds like most people are dying of lung cancer, maybe because we're being more successful with the other cancers or something, but what makes lung cancer particularly hard to deal with?
I think a lot of times when we determine that you have lung cancer, a lot of times the cancer has spread, and that's the whole thing. The challenge with cancer, can we screen cancer more effectively? If we can we, for example, lung CT scans have been used, low-dose CT scans were done for screening for lung cancer. So I think that makes a difference for people who are at risk, like smoking. But there are people who have lung cancer who've never smoked. And so what do we do? Do you order a CAT scan to everybody? Well, then, once again, issue of costs, how we're going to pay for that. And so that's a whole, risk-benefit ratio and public health issue, so to speak. I think the challenge with lung cancer is that if you catch it early, you can make an impact, but even then, they're still at risk of spreading. So I think even though there are advances in terms of targeted therapy for it, I don't think we're to the point where we've cured every single patient with lung cancer or can cure it. Yes?
There's kind of the overarching canopy of you should eat healthier, exercise more. Can you speak to the technical aspects of why physical activity and eating well particularly sets you up for cancer prevention?
Okay. Once again, I'm going to give you broad things. I'm not an expert specifically on how it leads to cancer, but the thought process that, for example, having for obesity, right? So the hypothesis there is that fat generates a lot of inflammatory cytokines, proteins, and these inflammatory mediators or cytokines or proteins over time predispose you to cancer, causing inflammation, and then your cells become abnormal, dysplasia, and then over time precancerous, and then over time become cancer. So that's a thought behind people with obesity. And you see it with, and then for example, pancreatic cancer, they think the diabetics, type 2 diabetes associated with obesity, that may be a risk factor, insulin resistance, and that type of thing. So I think that's the thought process there for fat, for obesity, so to speak. For the diet, you would like to believe that you're going to eat more healthy, have a healthier microbiome in the gut. I didn't touch on that, but that's in our colon, or we have a bacteria flora. We all have it, and what it does is helps process food, but it's just what we have. We still don't know much about it, but it does interact with the immune system. So by eating a well-balanced diet, variety of diet, less processed food, you have a healthy microbiome that can be protective against cancer. So, and that's been shown in another study way back when they compared Japanese who lived in Japan, then they migrated to Hawaii, and they came to the U.S. And they found that Japanese who came to the U.S. who ate a very Western diet developed a lot of colon cancer. If you look at Japan, Japanese who live in Japan, they don't get colon cancer. They don't have that. And it's because their diet is much better for not getting colon cancer. Well, the Western diet is, and they eat more vegetables, whole grain rice, fish, that type of thing. Well, the U.S. you can sort of know what we eat. Just go down the street and I can go there. So I think that's what they thought is there too. And then, so I think the diet is, so that's why there's a big emphasis on plant-based diet, and both for heart conditions, everything, so I think that's why plant-based diet is the way probably to go. Okay. Yes?
So has any progress been made on folks who develop pancreatic cancer because of genetics?
So that's an interesting thing you bring up. Back about 5 years ago, they actually started recommending patients with diagnosed pancreatic cancer should undergo routine hereditary screening. And what they found is that a lot of patients with pancreatic cancer had undiagnosed hereditary conditions that put you at risk for pancreatic cancer. Still not that much, 5 to 10%, but but they do recommend it. And so the classic one's BRCA, that's a BRCA, they associate with breast cancer, but it's also been associated with pancreatic cancer. So we're now screening for that. But I don't think we fully know all the mechanisms for cancer there either. I think it's a pathway, right? We start the pathway and then we walk down it, and then eventually things make more sense with time.
Because there's pancreatic cancer throughout my family on my mama's side.
So
For screening or
what I would probably suggest is you seek a referral to a geneticist. They can map out the family tree and see if there's a hereditary line that can be checked. The challenge though is a lot of times you don't find anything. So what does that mean? It means we haven't found it yet. Okay, or there's a common environment that predisposes one to cancer. But I suspect there may be a mechanism we haven't found yet. And it's because we don't know about it, we can't test for it. You can only test what you know. Okay, yes. Yeah, do you have a question?
Sorry. Yeah, so more of a clarification. So my husband has a significant family history of colon cancer. He's 30. When would you recommend him being screened?
So the first thing is how young of an age when the first person had colon cancer? How old?
That I don't know.
Okay. So once you find that out, then you should be screened 10 years younger than the age of diagnosis. Okay. So if they were diagnosed at 30, they should screen at 20. If you're screened at 20, well, I don't know about 20, but yeah, 10 years younger than 8. And the reason is that we believe that the cancer starts from a polyp, small growth, usually benign, but some of these polyps over time become precancerous, and then over time they become cancer. So if you catch a polyp early enough, during the colonoscopy, the gastroenterologist will go ahead with during the colonoscopy, they'll just snip it right off and one and done. So I tell folks, you may not like going through a colonoscopy. I've had one done. And you don't like the prep. I've had them too. But one night of prep versus going through chemotherapy, surgery, visit with me, I think it's sort of a no-brainer. You probably want to get your colonoscopy. And, it's just only one night of inconvenience. All right, yes?
I have a question related to Judy's question. My niece has done some gene testing because of history of breast cancer. Would you talk about that a little bit, about the gene variant that might be in your family lineage, at least for breast cancer?
Okay, so breast cancer is a little bit out of what I normally do, but there are hereditary conditions. You can look up online and see what they are. And by the way, some good websites for y'all if you want to just read cancer.gov, G-O-V. That's the NCI, National Cancer Institute. The cancer.org, that's American Cancer Society. And then cancer.net, that's our professional organization. So there are certain hereditary risk findings for breast cancer, and you can ask your geneticist or internist or oncologist to order those tests. But a lot of time when you order the test, you should have someone medically go over that with you, because just because you order the test, you may find genetic findings that we don't know what they mean. They call it variant unknown origin, or unknown significance, which means we found something, we just don't know what it means yet because no one has figured out what it means yet. And so sometimes it raises more questions than answers, so you have to be sort of careful when you find them. So I tell folks, sometimes be careful what you ask for. You may not like what you get, and then you have to figure out what it means, or if it means anything at all.
So I have a comment and a testimonial. So Dr. Wong has been my oncologist for 13 years. He's an incredible doctor, and the value of clinical trials and the value of advocating for these drugs to be paid for through insurances or whatever. I was diagnosed with a GIST tumor in 2010, and Dr. Wong took care of me since that time. Around a year at that time, the research had just been done, so I've been on Gleevec all that time since. Unfortunately, like a lot of things in my life, I'm an outlier on some things because then I had a small recurrence. And so Dr. Wong and I talk all the time about I'm an outlier now, so we kind of like agreed what should we do next, and there's not a good answer to that, but I continue to take the oral chemo, and 13 years later, I'm still here, thanks to wonderful care. And the most important thing is that first year when we were talking about this drug, at that time, it was cited to me that it was going to cost $6,500 a month. And I had the resources or would have figured out some way to probably do that, but I think about all the people in the world and my association with the Temple Community Clinic where you don't have access, and it's a sad commentary that there's something that could prolong your life, could cure you, that some people simply don't have access to. So it's really important that those kinds of drugs are supported. And I think over the last 13 years, my understanding that has become more prevalent in terms of being supported through insurances and whatever.
Yeah. So right now, a lot of times there are foundations to help patients for co-pays, for quote uninsured. So if you're uninsured, ironically, you can get the drug almost for free because you're uninsured. The problem is not the uninsured, it's the underinsured. And that's where it gets a little more tricky and challenging. So a lot of times there are foundations that help support the differences. Whole nother discussion, very complex. We could spend all day talking about that. That's more a factor of a healthcare system than anything else. So, okay. Yes?
Person had a polyp, say at 30, and had continuous colonoscopies through the years. Who was eventually told that they don't need any more colonoscopies.
So polyps are, there are different guidelines out there. So that's the hardest thing for me as a physician. Everyone has their own guidelines. There's American Cancer Society has a guideline. U.S. Preventive Task Force has a guideline. The American Gastroenterology Association has a guideline. So everyone has different guidelines. So the one that I sort of lean towards is the one where if you have a polyp, then usually we recommend another colonoscopy, usually every 5 years, as long as you have a polyp that really is worrisome for cancer. So what happens at a certain age? Usually at 80, they say maybe you should not routinely be screened for colon cancer. So that's sort of what the guidelines said. Have I seen patients over 80 with colon cancer? Yes. 90-year-old? Yes. So what do I do then? So a lot of times it becomes a discussion with the patient. If they're healthy and they're willing to undergo, because the problem with colonoscopy at an older age, there's a little bit higher risk for complications of perforation, so that's where the fear comes in. But if your risk is higher to get colon cancer, well, I think you have to think about that. So that's just a matter of discussion. And I think the challenge as physicians, guidelines are guidelines, but patients are individual, right? So you look at guidelines, they're based on hundreds of patients, thousands of patients, and they have to pick a point somewhere to say, okay, this is a cutoff. But we know that everyone's different, everyone's individual, so you have to sometimes know when the guidelines doesn't apply to this person, and you have to advocate for the patient, and that's what you have to do as a physician. It's always challenging, but it's just part of what you do. Yes?
So these nasty little polyps that keep getting removed, is there a way to prevent them from forming in the first place?
Well, right now the best that we have is what Dr. Sulek has proposed, diet, exercise, weight loss, and I do think that diet is a big component of it. I mean, I can tell you what I ate as a child. I would never feed that to my kids. I mean, so, well, that's what I had to eat. I'm a product of the public school, system. So processed food, all that stuff that's what they fed kids because it was easy, dump and pour, so to speak. And so we know that's probably not the best thing. But yeah, I think you have to look at your diet. The challenge, of course, is well, I don't know how old you are. I don't want to ask, but we're at the point where everything's all set. The die's been cast, right? So when you're young, you can do preventive things to prevent the path going forward. Once you reach a certain age, well, the die is set. We're sort of on this path. So we can prevent what's going to happen to us in the future, but then we can't fix what's in the past. So you're sort of stuck with where you're at. Yes?
Does Carter went through any genetic or gene research in relation to cancer, or is it all farm related?
No, we do. Dr. Blazo is our geneticist, so she does our genetic counseling and screening for patients. We as physicians can also genetic testing as well. I think the question is, if you order the test, you have to be able to explain it and discuss with your patient what the finding is. In terms of research, a lot of when we're doing our testing, we are doing tumor gene sequencing as part of our management of the patient, but I don't know if that's the same thing as what you're asking for hereditary gene screening, so that's a slightly different path. Yes?
You said something about having a healthy microbiome.
Oh, biome. Okay, so what that is in our colon, we all have bacteria, healthy bacteria, and what you want to do is to keep it healthy, or so to speak, is to eat a well-balanced diet, a variety of things, not the same thing over and over. So we believe that having a healthy microbiome may be cancer preventive, maybe, and also, and what we're studying to see right now, I'm actually collaborating with Dr. Greathouse over at Baylor University to see that by modifying the microbiome, maybe in the future, will help enhance cancer treatment, or at least lower toxicity related to treatment. And then also maybe if you modulate it, maybe prevent cancer. I mean, those are things that are being looked at. Nothing is finalized.
We take it like probiotics, help that.
Good question. I think that jury is still out. I think it's very healthy for certain conditions. You probably heard C. difficile colitis. I think that's where it makes a difference, maybe. But in terms of cancer prevention, unclear. Yes, a healthy diet. I just can't say taking a probiotic pill is going to prevent cancer. I think we're not there yet. Yes?
What about curcumin?
Curcumin's been looked at for cancer treatment and prevention. The data was inconclusive for that. We actually did a trial on that and looked at that, and it didn't pan out. It doesn't mean it doesn't work. We just don't. I think it depends on what setting you're looking at. Cancer prevention, cancer treatment, and so I think, and also the percent. I think there's a lot of questions that have to be answered, but so far that hasn't panned out, so to speak. Yes.
Tell me your opinion on Cologuard versus colon screening. I
Okay.
get a lot of pushback.
Yes, I understand. Okay. So the best colon screening test is, I was told, is the one you can get your patient to take. Okay. Right? So if you're not going to get the colonoscopy, okay, then do the Cologuard. So the Cologuard is a test which you can check for microscopic findings of hemoglobin, and which would be a sign of bleeding from cancer, and you would do that. So if you're not going to have a colonoscopy, then you should have a Cologuard. But what happens if Cologuard is positive? Guess what? You're still going to get the colonoscopy, and so then you have to prep yourself. So people don't know this, but there was a while back that they were looking at virtual colonoscopy from CAT scans. But guess what? You have to prep yourself just like a colonoscopy with the CAT scan for the virtual colonoscopy, and then afterwards you still have to get the colonoscopy. And so I would tell folks, well, you can do that. Why don't you just do it? And you can And my wife was the one who introduced me. Have a clear liquid diet 2 days before the procedure, clear yourself out. Then when you take the prep, it's not that big of a deal, and then you're done.
No, that's not true.
Yes, it is.
It was not a clear liquid diet. It was gelatin with fruit fly. There's certain. Okay, so the bottom line is there are certain juices that are clear. Okay, so do not get the red one. That's not a good one. You want to get the apple juice. Or
The lemon.
Green, no lime, no green.
No green, but lemon.
Clear.
Clear.
So it has to be apple juice is clear, and green grape is clear. And you can mix it with gelatin to make like kids put blocks, fruit blocks, and you can eat that. You won't get. So it's not. They consider it a clear liquid diet, but really you have to know is when you look at clear liquid diet, they think, oh, I'm going to be drinking the juice and I won't be hungry. No, you'll be hungry. You want to mix it with Knox blocks or gelatin.
Okay. All right. Any other questions? Yes.
Do you have any recall of any of your patients complaining about the prep for the colonoscopy? There's one particular prep that I don't ever want to think about again.
Okay, I'm not
God awful.
I'm not a prep expert, so I'm going to leave it at that. I think it's very interesting. You have to go. You'd be surprised how many different clinics have different types of prep. There's like Go Lightly, there's Miralax, all these things. So I think that's beyond what I normally do. I treat the cancer. I don't necessarily do that. But I do think there are different preps out there, and so you have to talk to your.
You haven't had any other feedback that's particularly like mine or anything?
Well, I think the one that I thought was really hard on a lot of patients was the Go Lightly because you drink gallons and gallons of that stuff.
Yeah, the volume.
So I think the Miralax one's a little better, but that's here at Baylor Scott and White. I suspect there are other ones out there that are probably different and tolerable. I think you just have to just find out which one works.
Yeah.
The main thing is to get a good prep. If you don't have a good prep, then you don't have a good look. And then guess what? You have to do it again. And you really don't want another colonoscopy again unless you really want to come and go. All right. Okay.
Let's give it up.
All right,
I got this colonoscopy prep thing down. Are y'all ready? I'm into fasting. So 5 days out of each month, I do a modified fast where I only eat one meal a day, and it's a great way to drop 5 pounds in 5 days. And it also increases stem cell production. So anyway, University of Southern California, fasting and get that. But before I have a family history of colon cancer. My aunt died of it. My uncle has a colonoscopy. My dad had polyps. So I've been through a few colonoscopies. And that first prep, I'm going, I'm not doing this again. And I thought, I'm just going to fast for about 3 days. And I just drink clear liquids, and you just get it out. And I never had to take the Ducalax and all that other stuff. And my GI docs always say, I've never seen a colon this clean. And it's a good way to drop several pounds. Okay? Just go on a clear liquid diet several days before, and you're actually just detoxing yourself and you're cleaning your system out. Makes good stuff. Any other questions for Dr. Wong? Wasn't this great? Everybody learn a lot? Fantastic. And we just love this series. Let's give it up for the Temple Community Clinic for making all of this possible. Sharon and Holly and the whole team, thank you very much. And we've got, we're going to be around in case anybody has any questions they want to ask in private or whatever. We're not going to be rushing out the door. And remember, next month we have Judy Holscher, who's right there. My buddy, who I've known many, many, many years. And Judy is so great. I had her speak at my last Women's Wellness Conference that I held last summer, and I had her speak on spiritual health, and it was very uplifting. And I'm so glad that she's volunteered to be our speaker next month. And it is a wonderful, wonderful talk, and I don't want you guys to miss it. Sherry, anything else?
No, thank you for having it here.
Oh, thank you, brother. All right.
That's good feedback for us.
Yes.
You know, we want to, and this is where our location will be until we move to the new clinic. They're on 31st Street, so that's good feedback. We wanted to make sure it was good, easy access for everybody. So hope this continues to work. Hope we can continue to fill up the room. We have made contact, like she said, Judy will be doing the next one. Dermatology and the vision department, different people are coming to speak on macular degeneration and how to prevent eye diseases, things like that. And dermatology is going to come talk about skincare. So we got lots of great things coming. So keep coming, bring your friends. And Holly is the expert now on taping these, and they're going on YouTube. And so they can be viewed later if you want to see them later, or share them with family and friends. So just go out to our website, give her a couple of days though. She's great, but she's also working at the clinic too. So anyway, that's about it. And again, we thank you guys for coming and sharing with us. We hope to have you again.
Oh, thank you.
All right, thank you.